Okay, let's dive right into this. Welcome to This Explainer. If you've ever wondered how modern medicine can literally reach down to the cellular level to, say, stop a racing heart, fix plummeting blood pressure, or even save a surgical patient in real time, well, you're absolutely in the right place. Today, we're talking about the ultimate pharmacological defense mechanisms, the adrenergic antagonists. So, shields up.
Here's our roadmap for today's journey. First, we'll meet the adrenergic antagonists. Then we'll look at alpha blockers and how they lower pressure, followed by beta blockers, our heart shields. After that, we'll get into the selective and special beta blockers, and we'll wrap the whole shebang up with the outliers that completely deplete our neurotransmitters.
So, Section 1, meet the adrenergic antagonists.
You can really think of your body's natural fight or flight chemicals, those endogenous catecholamines like epinephrine and norepinephrine, as perfectly cut keys. Now, normally, they dock right into their cellular ports, these locks we call adrenoreceptors, and that turns on this massive physiological response. But adrenergic antagonists, which are also called sympatholytics, well, they act as molecular shields. They bind to these exact same receptors, but here's the kicker. They don't turn the lock. They just sit there. By taking up that space, they basically act like a physical plug, stopping the body's natural keys from docking and triggering their usual effects. It is a brilliant shields-up strategy. Moving on to Section 2, alpha blockers, lowering pressure. To really grasp how these alpha blockers operate, we kind of have to look at how tightly they hold their ground. Take phenoxybenzamine, for example. This drug doesn't just block the receptor, it actually links covalently right to it. It's an irreversible, non-competitive block. Imagine literally super gluing a broken key inside a lock. Actually, scratch that, it's more like welding it shut. The only way your body can overcome this block is to synthesize brand new adrenoceptors completely from scratch, and that takes a full day or more. Now contrast that with phentolamine. Phentolamine is essentially just putting a piece of tape over the keyhole. It creates a competitive block that lasts for maybe 4 hours after an injection, and it's easily overcome once the drug washes away. And this brilliantly illustrates a phenomenon known as epinephrine reversal. Think about a patient's normal blood pressure. Now, if you give them a shot of epinephrine, their blood pressure naturally spikes, right? Because epinephrine stimulates alpha receptors, causing intense vasoconstriction. But get this, if you pre-treat that same patient with an alpha blocker and then give them epinephrine, their blood pressure actually drops. No way, right? Why does it do that? Well, because the alpha blocker acts as a shield over those vasoconstriction receptors. So the epinephrine is literally forced to only interact with beta-2 receptors, which actually cause vasodilation. The alpha blocker literally reverses the expected action of the adrenaline. It's wild. But we have to move fast here, because these powerful cardiovascular shifts come with some serious high-stakes drama. When we use selective competitive alpha-1 blockers, think prazosin, terazosin, or tamsulosin, to treat things like hypertension or an enlarged prostate, we can run into some completely wild adverse effects. First up, the first dose effect. Literally, the very first time a patient takes this drug, they can experience this hugely exaggerated drop in blood pressure the second they stand up, leading to sudden syncope. Basically, they just completely faint out of nowhere. And if that wasn't dramatic enough, these agents can cause something called floppy iris syndrome. If a patient is on an alpha blocker and goes in for eye surgery, the blocked receptors in their eye can actually cause their iris to suddenly billow and flop around during the operation. Definitely not what you want on the operating table. All right, Section 3, beta blockers, the heart shields. So I want to share a little pattern recognition secret with you. One of the best cheat codes for this class of drugs is the super simple pattern. Almost every single beta blocker ends in the suffix -olol. You've got propanolol, the non-selective prototype, metoprolol and atenolol, which are your cardioselective agents, timolol, the eye specialist. Honestly, when you see olol, you know for sure you're looking at a beta shield. But there are two notable rule breakers here, labetalol and carvedilol. They don't end in the traditional olol because they aren't just beta blockers. They actually have dual action, blocking both alpha and beta receptors to provide some really unique peripheral vasodilation. So the crucial point is, you absolutely have to know exactly which type of beta receptor you are blocking, because a simple mistake here, it can literally be lethal. Propranolol is a non-selective beta antagonist, which means it blocks both the beta-1 receptors in the heart and the beta-2 receptors in the lungs. In the lungs, blocking beta-2 causes the bronchiolar smooth muscle to contract. If you give a non-selective drug like propranolol to a patient with asthma or COPD, you are essentially stripping away their airway's ability to stay open.
Tragically, death by asphyxiation has been reported when asthmatic patients were inadvertently given these drugs. It is a fatal contraindication. You just cannot risk it. But when used correctly, these shields are incredibly precise. Take glaucoma management, for example, where there's dangerous pressure building up inside the eye. We can actually use a topical beta blocker, like timolol, directly in the eye. It acts as this highly specialized shield to decrease the actual secretion of aqueous humor fluid from the ciliary body. Now, unlike older cholinergic drugs like pilocarpine, which work by physically forcing the fluid to drain and completely changing the pupil size in the process, timolol just quietly turns down the faucet. It lowers the pressure without affecting the eye's ability to focus, and it doesn't change the pupil size at all. Next up, Section 4, Selective and Special Beta Blockers.
Now, what's really interesting here is the concept of intrinsic sympathomimetic activity, or ISA for short. Normally, we think of antagonists as pure shields, right? They block the receptor completely, kind of like propranolol, which heavily decreases heart rate. But drugs like acebutolol and pindolol, they're partial agonists. They actually act as both a shield against the body's potent adrenaline, but simultaneously, they act as a very weak key themselves, so they weakly stimulate the receptor while they sit in it. What this means is they prevent the heart rate from skyrocketing during moments of stress, but their weak stimulation prevents those extreme severe drops in resting heart rate that you might see with a pure antagonist. It's literally the perfect balancing act for patients who already have moderate bradycardia.
And speaking of highly specialized tools, check out this number, 10 minutes. That is the remarkably rapid elimination half-life of intravenous esmolol. Because it has a specific ester linkage that is super rapidly metabolized in the blood, it enters the system, does its job of blocking beta-1 receptors, and completely disappears in just minutes. It's the ultimate quick dial tool for surgeons and ER docs who need minute-to-minute rapid blood pressure and heart rhythm control during a procedure. If the heart rate drops a bit too low, they just turn off the IV and the drug is gone almost immediately. It's a real game changer. Finally, Section 5, Outliers, Depleting the Neurotransmitters. Let's move to and see how this builds into a totally different pharmacological blockade using reserpine, which is actually a plant alkaloid. So instead of just blocking the receptor, reserpine goes right into the nerve terminal itself and blocks the transport of biogenic amines from the cytoplasm into their protective storage vesicles. Left completely unprotected, the body's entire supply of norepinephrine, dopamine, and serotonin is just slowly destroyed and depleted. As a result, sympathetic function is broadly impaired for days even after you stop taking the drug. Why? Because the nerve literally has no chemical messengers left to fire. It's a slow, total depletion strategy. Now, it's largely been replaced by newer drugs today because of its side effects, but mechanically, it is absolutely fascinating.
Which brings us to the end of our journey today, and it leaves us with a pretty critical question to ponder. Looking at all these incredible molecular mechanisms, from irreversible covalent superglue to dramatic epinephrine reversals to weak keys that barely turn the lock, are we truly mastering our body's fight-or-flight response? Or, with fatal asthma warnings and sudden syncope just waiting in the wings, are we just playing a delicate, dangerous game of molecular musical chairs? The science is completely life-saving, and the precision is astounding for sure. But the physiological balancing act? It's absolute peril. Thank you so much for joining me for this explainer, and I really hope this leaves you wanting to learn even more about the incredible world of pharmacology.